Welcome to everyone. We are very happy and proud to have organized this meeting since the European Commission suggested to the ERN to organize a meeting in which we can share our experience and expertise. So this is the first of a series of meetings. And we are so happy since in this program there are a lot of very interesting good practice to be shared. I give the floor to Ilaria and then to Marta for a brief introduction, and after that we can start. Please, Ilaria.
Thank you, Sarah. Thank you, everyone, for being here and for sharing your good practices. We ran a similar exercise in Italy 2-3 years ago, and it's been really, really useful because, as Marta always says, don't reinvent the wheel. Use what the others already are doing and work. So here we are again, and I think this is one of the main aims of ERNs, to import and export good practices. So thank you again, and please, Marta.
So I'm just adding my voice to Sarah's and Ilaria's, and I would like really to underline the importance of sharing the expertise and the practices that we have. So what to say? Thank you for accepting. We will have other meetings because we had other proposals coming to us over these days. So there are so many things that we can share, and so I'm looking forward to hearing from you. So what to say? Let's start.
Okay, thank you, Marta. So we have this very interesting program, and we can go in the order of the program. So it's a pleasure to give the floor to Dr. Vierne, if I'm not wrong, for talking about organization of inpatient care in a reference center for non-vascular Ehlers-Danlos syndromes.
Good afternoon. I will share my screen. Can you see it?
Yes, perfectly.
Yes. Good afternoon to all. I'm Baptiste Vierne, I'm project manager. I work in the HCP Raymond Poincaré in Garches, France. And I work in the unit of Dr. Karel Benistan in the Reference Center for Non-Vascular Ehlers-Danlos syndromes. So before speaking of good practice and organization of care, I just would like to share with you a quick reminder on Ehlers-Danlos syndromes. Ehlers-Danlos syndromes are genetically and genetically heterogeneous group of rare and heritable connective tissue diseases. EDS are characterized by this triad: joint hypermobility, skin hyperextensibility, and tissue fragility. Those the three major symptoms. But EDS can also lead to other manifestations of tissue fragility. And that's why patients can have multisystemic complication, and that can result in locomotor disability, chronic pain, but also many comorbidities on a different plan, like rheumatological, gastroenterological, etc., etc. There is 14 subtypes of EDS, with some of them which are very rare, and all genetic subtypes are known to be caused by defects of extracellular matrix proteins, and the estimation of the prevalence is 1 for 5,000, and in French, the estimation is around 12,000 individuals. But some types are very rare, but some other less, like a classical type or hypermobile type. I will now, I would also like to enlighten you on the organizations for rare diseases at the national level in France. The French Ministry of Health has launched a rare disease national plan that give an organization of care with rare diseases reference and competence center. That's a 5 years labelization. And a new labelization is ongoing. But we decide first in 2015, the first EDS centers were labelized in France in this program, and in 2022, next year, a new labelization is ongoing, and we propose this new network for non-vascular EDS with 3 reference centers, 1 coordinator, which is the Raymond Poincaré Hospital, the unit of Dr. Karel Benistan, and 2 other constitutive centers that also are reference centers, and 2 competence centers. The difference between reference and competence center is on the missions of the centers. Reference centers have more missions, care of course, but also expertise through documents, tools to give to all the patient or clinicians, but also a lot of tools, documents on EDS. And the other missions are coordination, research, teaching. Just to make a little point, our network is can rely on one of the 23 rare filières we have in French. Our filière is OSCAR and includes 4 networks in relation with bone and cartilage diseases. And we can also rely on a rare disease platform. And we also work with the 3 national patient organizations that are attached to the filière OSCAR. Just to clarify one point, the vascular type of EDS is included in the rare vascular diseases network, another network, and is as well in another URN, the VASERN. Okay, now for talking about good practice, I will give you the example of multidisciplinary centers. Our centers, I will talk about the patient's care pathway in our units. This is an independent unit with Dr. Karel Benistan as head, and I will present you rapidly the team. There is clinician, 2 full-time and 2 part-time. We have also paramedics, professional, and other like medical secretary, nurses, care assistant. And we are 3 research engineer and project manager for all the missions to support Dr. Karel Benistan in all missions of Rare Diseases Center. And we have also on schedule a dietitian, social assistant, or orthostist. This is a multidisciplinary team that can help us on the pathway and the organization of care. We have some facilities in our units that can help us a lot in the day. We have a consultation room for consultation with the clinician. We have 2, in fact. We have also a waiting room, a re-education room, and a psychological office. And at Raymond Poincaré Hospital, we also have other equipments and facilities for all the care like a radiology department, laboratories, medical and anatomopathology, functional exploration. And for management, for therapy, we also have wheelchair apartments and a rehabilitation platform. And a gymnasium that you can see on the picture. So I will now talk about our organization for day inpatient care. We see patients on the day hospitalization care. But before we have a lot of requests of appointment also for suspected diagnosis, and for those requests are for confirm the diagnosis of EDS, and also for follow-up. But I will present you now for request for suspected diagnosis. Patient can request this appointment, but also generalists can send a patient through a letter, a referral letter, and a patient organization can also send us a patient for suspected EDS, and we ask a referral letter from a specialist and, if possible, a heart echo before the appointment to help us prioritize the request. And we have two different ranking. First, when it's an emergency, and for example, an ongoing pregnancy, for example. And for those cases, we are short-term consultations that are really specific to those emergency requests. But for non-urgent requests, we ask a patient to fulfill surveys and to send us their medical file, some information, and then the clinician can study this file just before made a teleconsultation with the patients to see with the patient their history about their diseases, their problems, and when it's not revealing about the suspicion of EDS, they can be redirect towards other specialists if this is, for example, another connective tissue disorder, and the clinicians know that this is probably more that than EDS. And for patients where the clinicians think it's really evocative of EDS or HSD, it's hypermobility syndrome disorders, their program and their hospitalization, the day inpatient care, that is organized with nurses and clinicians. And I will now present you the patient's journey during this day care, this day hospitalization. At their arrival, they are received by the nurses that prepare the patient for investigations with they explained the day, they prepare the patient for all the hospitalization. Then they have appointments for medical consultation with clinicians and nurses, but also for complementary investigation like a medical imaging exam. We have the radiology department that we can make vascular exam to be sure there are no problem on vascular. There's not, if there is no vascular issues, but patient can have a global evaluation of his needs through a psychomotor therapist, physiotherapist, psychologist, dietitian, ergo, social assistance if needed. And this is the one of our force in this situations. There is just not one clinician consultation, but a whole team that can work together. We also have specialized consultations with orthopedic surgeon, pain doctor, or neurologist, for example, orthotist, if needed. But the team and the global evaluation of the patient can lead to a synthesis and a whole evaluation of the patient to have a good diagnosis at the end. For the patient, at the end of the day, they have a synthesis by the doctors and the nurses, and we send them a medical report at the end of the day hospitalization. Just to focus a little bit more on diagnosis question about EDS and care management, I will present you how clinicians work during their consultation. What are the options at the end, and the follow-up and the care management possible at the end of the consultation. First, the clinician introduce the consultation. Then they're questioning the patient about their family medical history, disease onset. They make the genealogy tree. Some of these parts may have been done during the teleconsultation, but it's good to question a second time the patient to be sure that we have a whole view of the patient medical history. Then there are these clinical examination, including a photo shooting, so the clinician can see the hyperlaxity, the tissue, the skin cicatrization, for example, to be sure of the diagnosis. And for hypermobile type, they can also fill the form, a criteria form, and if a patient fulfills the criteria for hypermobile type or other EDS form, some rares, the clinician can conclude on a diagnosis, but they have also a lot of job to do after this consultation, and if the diagnosis is post, because for rare diseases subtypes, there is a molecular confirmation needed. So the care and the follow-up will be around genetic, to organize the genetic testing, the counseling. But also there is other needs for the patients. So there can be multidisciplinary consultation, follow-up consultation. It depends on the evolution of symptoms for the patient. And depending on symptoms, a patient can be referred to the right specialist. It can be a lot of different specialists, but I will talk about it just later. But we have also a therapeutic education program to help the patient in this disease. So I will just talk a little bit about our program. This is a program dedicated for patients diagnosed with EDS in our center. This program has started in 2019, excuse me. And the main objective are to ensure the continuity of care for the patients. It also enables the patient to learn more about their pathology, their symptoms, and also learn more about genetic transmission and mechanisms, because with genetic diseases, it's important for the patient to know what could be what it leads to, and they can learn about their social rights and how to become autonomous, independent, and moving around, managing pain, and seeing their symptoms. I will now talk you about multidisciplinary networks. It's really important. As I say, EDS are diseases with multisystemic complications. And as you can see in this figure of an article of Francisca Malfay, there is a multitude of complications that are that can be treated by different specialists. And even if one patient have not all complications, but just some of them, care management are for each patient requires a therapy, and care management can be really specific. So clinicians for our center works with a lot of different specialists, as you can see in these slides, to help and manage the care of our patients. So just to conclude, a multidisciplinary center as our allow us to organize day in patient care, so to carry out an overall assessment of the patient in order to establish a diagnosis. But it also allows us to organize follow-up for EDS patients, like genetic consultations, physiotherapy sessions, and etc. But also allow us to organize a therapeutic education program. So just a take-home message, it's that we can be specialists in every domain. So it's important, it's a need to refer to a large network of specialists, because referrals that have the double expertise, that are formed, interests, and sensibilized on rare diseases, it's really important. And a national network that is coordinated can also improve the patient's pathway and the management of care. And it's good also to federate clinicians around a rare disease, in our case, EDS. Thank you very much.
Thank you, Baptiste. Thank you for this excellent presentation. Actually, there are at least 2 questions that I can see from the chat. I don't know if you, Diana, are you seeing other questions? One from Christina. Hi, Christina. Congratulations for this excellent setting for EDS patients. How can we refer patients from other countries? So I think she's referring to the cross-border, probably taking care of patients.
This is a good question. We have not yet some cross-border refers pathway. We have not in place. This is not in place in our center, but I don't know. Dr. Carol Beniston is here, but maybe she have more.
Yes, sometimes we have some patients who are coming from other countries, but it's very rare at this time. When they ask, they have to have an organization with our hospital to have all the paper and to be reimbursed if they want. So there is something in our hospital to propose for these patients, but it's not so it's rare. It's rare.
Okay, thank you. There are raised hands, but there is another question. So please, Eric, and then Coralie.
No, first Coralie, because she was, her hand was all
I see the order on my computer, sorry.
So thank you, Baptiste, for the presentation. What you have to understand, filière Oscar is another filière. My filière is FAD2R for connective tissue diseases. In France, Ehlers-Danlos is in another filière. So the filière in France are like the ERN. So you understand. So ReCONNET, for example, is the same as the filière FAD0. Oscar and Ehlers-Danlos is another filière. So, but also what you have to understand is exactly the same as in Europe. The ERN are not caring network, but health network, and HCP are care networks. So it's a little bit different. So the HCP have to care patients, ReCONNET have to organize management of the patient, etc. So it's exactly the same. Also in France, all the referral centers are receiving a grant from the health ministry between 200,000 and 300,000 euro per year. So this helps to organize such a beautiful network that Baptiste has presented. Moreover, and I will speak about patient education, therapeutic patient education, it's mandatory. We have, as HCP in France, in a filière, we have to develop patient education. It's mandatory. It's mandatory because it's written in the hospital law. And what are the competence centers of his network is like our affiliated members. So they receive nothing from the health ministry. They have to organize their own network in their own center. So this is just to clarify exactly, but it's really nice, Baptiste. Beautiful.
Thank you for this nice clarification. Please, Coralie.
Yeah, good afternoon. Thank you, Baptiste, for your presentation. Baptiste, I'm curious about one thing. I saw that patient can ask directly to you for a consultation. You probably have a lot of patients who search the internet to find what's going on with them, like in many disease. I was wondering what proportion of patients actually have EDS when you test them and when you made all the pathway. Do you have an idea of finally?
This is a really good question. Not a lot. Not a lot, but I don't know. Maybe Dr. Beniston have.
I can answer, Baptiste. It's
yes.
around 10% of people who are being in the unit, and we try to have only people with an authentic hyperlaxity who are coming to us. We check that before to come, and when they are in the unit, it's only 10% who are really Ehlers-Danlos syndrome.
Okay, Thank you.
There's a lot of people who have hypermobility spectrum disorders without all the criteria of EDS.
Okay, thank you.
Actually, I can tell you because I have the statistics in front of me in France. In the National Bank of Rare Diseases, we currently have hypermobile patient, it's 2,000, and other classical Ehlers-Danlos, we have about 1,200. So it's the number of the patient in our national database.
Thank you.
Yes.
There is also another question from Janet. Hi, Janet, thank you for the question. It is a very important question also related to the framework of the ERN. Which role did patient organizations or patients have in setting up this multidisciplinary approach? Is there any role in they join the discussion of this, the creation of the multidisciplinary approach or in the journey?
For example, I know that for the therapeutic education, we worked a lot with some organizations, some expert patients to help and to design this program really to answer the need of the patients. This is the point. Maybe
I didn't hear the question, all the question, but I heard that it was on patient organizations. The role.
Which role did patient organization have in setting up this multidisciplinary approach?
Yeah, two things to know. One is that we have recurrent meetings with our 3 patient associations. We have more than 3 EDS associations in France, but 3 of them are national and are attached to the filière. So we are working together and we have a meeting once a month. And we are discussing on care in the unit and about projects. And in France, I don't know in the other countries, but patient organizations, people from patient organization can be educated to education program and can participate as expert patient. So it's very useful to have their feedback to adapt and to progress in the program, because the program is always in movement, you know, and so it's we have to adapt always.
Yes, of course. Yes, yes.
And patient organizations have a role on national pathways of care. They help us they give us some feedback from all over the country, and they are really helpful to understand the national problems of pathway, and problems or not. Sometimes it's good thing that works, but they're also important for this.
Thank you, Baptiste. Thank you, Karel. Maybe for next time, prepare a good practice on your collaboration with patient organizations, because it seems to be very, very interesting and productive, and not very common, let me tell you.
Yes.
Now, yes,
I have a very short question for both. Since in 2 years ago, in December, we had the meeting for rare and path application for EDS. And if I'm not wrong, you joined the discussion probably. But in any case, the approach of apply these methodologies to check and to map the organization in the different centers. So I'm taking a question from the application itself. So the question for you is, which kind of challenges do you have in the real life in the application of this approach from the organizational point of view, of course, if you have?
The main point for me is to build the network of specialists and to have the team, the multidisciplinary team that works daily in the center. And if we have no funding for this team, we have no team, no day hospitalization, and it's really hard to apply this organization. And for and for the specialists, the referrals, it's really time and to networking and work with all specialists in our country. A lot in Paris, in AP, HP, but yes, it's the 2 points that are important, I think.
Thank you. And thank you again for this very nice presentation. Ilaria,
thank you.
Great. Thank you very much. Now we have Eric Hachulla from Lille, who will share with us his activities on patient education in rare connective tissue diseases. Eric, we are already 11 minutes late, only after the first presentation. So you know what to do.
I share my screen here, probably now. You see my screen? No, yes. So I will tell you about patient education. As I said just before, it's mandatory for national centers receiving grants from the Health Ministry to develop patient education programs. And I want to share that with you. We had a survey a few years ago with ReCONNET, asking to the patients in the EU, do you know about patient education? And 3/4 of them said, no, never heard. So we have lots to do. We have a whole definition of patient education. As you can see, the definition here is patient education should be designed to help patients and their families understanding the disease and treatment, cooperate with healthcare providers, live healthily, and maintain or improve their quality of life. It's a process, it's a continuous process, actually, to improve the quality of life of the patients. And it's also a journey. This starts by an education diagnosis. What is an education diagnosis? You have to stay, you, a nurse or a healthcare provider, you have to stay 1 hour with the patient with a questionnaire. We have developed a specific questionnaire in France. We have done it in English, and we can translate it to every language you want, because we want to share our experience. And so discussing with the patient, you ask the patient what is knowing about his disease, his treatment, the relation with the family, with the partners, working partners, etc. And after 1 hour, you can propose to the patient, after that discussion, a personalized program. What is a personalized program? I choose the example of systemic lupus. Here, our specialized program on systemic lupus. Here, we have 5 different workshops of 1 day. The first day, for example, here is a workshop of systemic lupus. What do I really know about it? Take a treatment daily, why? Second is, as an expert, I recognize signs of flare or lupus and pregnancy in the afternoon. And third day, making my mirror and Ali. I read and understand the word of my specialist, etc., and managing my fatigue, living with systemic lupus. So after the patient education diagnosis, the patient choose, oh, I think I need only 2 or 3 workshops. And we give him or her date, and he can participate all the dates. He's coming not in the department because we think the patient has not to come again at the hospital, because arriving at the hospital, it's arriving where he suffers of systemic lupus. So we have a dedicated place to practice patient education so the patient feel more comfortable. And all workshops are with different specialists. It's mandatory. So we need a physician, of course. We need a nurse, sometimes physiotherapist, kinesiotherapist, dietitians, etc. So at least 3 different specialists, healthcare givers. And we have lots of tools. For example, here we have a dedicated workshop on how to deal with my fatigue. And we have lots of material to help the physician, to help the nurse to conduce the workshop. And one workshop lasts about 1 to 2 hours. And of course, everything can be translated and shared with you. We will discuss that, I think, with Mauricio, because he's a co-chair of the training education working group with me. For example, pregnancy, we have lots of material to discuss with a patient who wanted to plan a pregnancy or a patient who is pregnant. Here for transition, we have lots of material for transition, and this can help the transition working group, of course, to develop patient education and to develop transition, good practice in transition. Here, another example is Zika syndrome related to the brain or associated to systemic lupus. So we have lots of material, and this material is a box. It's an education program box, thema, dedicated to all connective tissue diseases. So this can be used for systemic lupus, systemic scleroderma, for inflammatory myopathies, etc. And after, we have dedicated and specific workshops depending on the disease. And after that, so maybe after several months, the patient during the workshop is with other patients, at least 2, 3, 4, 5, no more than 6, 7. And it's also very interesting because all the patients are discussing together and they are giving some tips to improve the quality of life. So this is implementation. And at the end, we have skills evaluation, and we have some tools to evaluate. For example, we have the cortico quiz. It's a game, and patients are playing together with a physician to be sure they have now a better level in the knowledge of corticosteroids. And we have the same for systemic lupus. We have sclero quiz, etc. And we have translated the sclero quiz, for example, in English. And also we can translate that to all the different languages of our network, ReCONNET. Here, the sclero quiz, and so patient, and I play sometimes with the patient. It's really funny because the discussion after, for example, one question, you can see it's level 3, so it's a high level. We have 3 different levels of questions. It's a questions about treatment. All lung fibrosis situations are treated with immunosuppressive drugs in scleroderma, true of course, and the physician or the nurse have the good answer, and patients are discussing together, and at the end, the patient, the physician or the nurse is giving the correct answer, and this gives some good and interesting discussion between patients and physicians. And at the end of the program, we give to the patient some material, so he can check that at home. At the end of the program, after 6 months, for example, the systemic lupus in 100 questions, and on the left we have translated it, and now in 11 different languages. Thank you for that. Some patients are implicated, and we can do the same for systemic sclerosis, Sjogren myopathies, etc. We have lots and several in France, and we can adapt this booklet to ReCONNET, of course. That we have done that for systemic lupus. And to finish, last not least, because we have developed and we are really involved in patient education with my filières that I'm coordinating, the filière FA2R, FA2R for connective tissue disease and autoinflammatory disease. We have developed European training course for clinicians and healthcare professionals to develop or improve their practice in MRD, connective tissue disease patient education. It's 4 modules with a partnership of EHLR, and ReCONNET is involved. And we have built that 2 years ago with several experts in patient education coming from France, Italy, Switzerland, UK, etc. And with also different patients who were involved to check all the material. And this was made in partnership with Alain Cornet. So this course is open in October, a new course with EHLR, and I've get grant coming from the Health Ministry of 30,000 euro for ReCONNET to propose to each HCP and affiliated member who is interested in patient education, who wants to discover patient education, what it is, who wants to practice patient education, to free registration for 2 members of the centers. So I will send them, we will send the emails probably this week or next week, asking each to register 2 members of his team. So I wanted to share that with you, open to discussion.
Thank you, Eric. You should do good practice of keeping presentation short. And I loved hearing that in France, some things are mandatory. So patient education, as well as the participation of at least 3 different specialists in this kind of work. I have the same question that Sarah addressed to Baptiste before. Which are the difficulties that you face daily for implementing this training?
The first issue, of course, is money, because we have to identify in our departments a nurse very interested in patient education, but also she has to have time to practice that. So there are 2 situations, because here the French centers identified by the Health Ministry have money. When I had certification from the Health Ministry in 2005, my decision was to put first money on patient education. So I identify 1 physician and 1 nurse totally dedicated to patient education. So it's an easy situation, but I know that the HCP here in Europe don't have, exception in France, money. So the second aspect, possible aspect, and I discussed with my cadre nurse, how it's a cadre, it's a nurse, chief nurse in my department. She can identify, it's possible in each HCP, I think, a nurse very interested in patient education. And it's possible for every HCP to dedicate it a time, maybe 2 half-days per month dedicated to patient education. Instead to be in the department and to care patients, she can extract the nurse and with a physician just develop 2 workshops per month, 2 half-days dedicated to patient education. And so she can apply and perform patient education, but to perform patient education in France, you have to be certified with the 40 hours training that I propose with EHLR. Because to have good practice, the third issue is to be trained to practice patient education. This is the third issue, I think.
That was my following question. We have a question from Magdalena Ciupera, an ePAG representative from Myozitdy. She asks if families of your patients can take this training as well.
Exactly. Usually we ask to the patient and his helper husband, wife, or somebody, somebody of the family, of course, they can't come. They can't come. And also we have dedicated patient education program dedicated to the helpers of the patients. We have, yeah, it's possible, of course.
I think I can talk on behalf of the whole ePAG group that we will be happy to help in translating the material to adapt it, because this is what we know. And may I suggest you, Eric, to bring also to Maurizio the idea of training the trainees. I mean, to help your colleague what should be done and avoided during these sessions. And if we also have the question coming from Matti, if it's possible to have it online, to have these sessions online, or do you think that the face-to-face meetings are still the best way to?
Actually, during the pandemic, the health ministry put lots of money on the table to develop patient education programs via Zoom. And we have developed specific programs. Nevertheless, this can only be done with physician, a nurse, and third professionals. So patient cannot go alone. It's too dangerous. Patient has to have explanation coming from physician, nurses, etc. Yes, but we have developed a program, and the themas that you have shown, the box, we have developed it on internet, and so we can practice with Zoom.
And I think that not only the ePAGs, but also the patient organizations all over Europe will be happy to disseminate and to improve if there is a possibility to improve it based on the local needs, on the national.
Yeah, we can do Diana, a webinar on patient education explaining. We'll see with the offer that we are all together proposing to the HCP. They're very interested in. We'll see. If we have only 2 registered people coming from all our HCP, it will be dramatic. If we have 200, okay, I will find money for that.
But if we have only 2, we have to say, Roger, we have a problem.
Yeah,
absolutely.
I agree.
Thank you, Eric. So I leave.
And just a suggestion for next time, for good practice, Sarah, Marta, Diana, I can explain how our CPMS in France is working, because in 2022 we have we had more than 200 clinical cases, and we discussed more than 200 clinical cases. I can next time explain how it works.
On the CPMS, Eric?
It's an equivalent of CPMS, the French tool. I can explain that, but not with my etiquette of healthcare provider, with the etiquette of head of the filière.
Sure. Thank you. Sarah, go on.
Eric, and before going to the next speaker, it obviously it's no need, but I would like to highlight that thanks to the exchange program, me and Diana went to Lille in the center of Eric, and we had the possibility to observe their work, and they are really masterclass in education. We learn a lot of things, and they are really something inspiring also for other diseases. So thank you. I was a witness of this huge work. So, okay. The next speaker is Olga Drápalová, and she will talk about education and exercise for patients of the Myozitdy group. Please, Olga, the floor is yours. Olga, you are muted. Eleonora, may we unmute Olga directly from our...
Sorry for that. Once more, I will share.
Okay.
Yes. Yeah. Hello. Can you see my PowerPoint presentation?
Not yet.
Not
You
yet.
have to share your screen.
Yes.
There is a green button, share the screen.
Yes.
You have to share and click on the slides.
Yes. Yeah, there is a green share, and then I open this document. Can you see?
No.
No. What happens? Just now?
You need to select which option you want to share with us. So I guess after you open you click on the green button, you have several options, right?
Yes.
Right, Olga?
Yeah, just now I opened this presentation.
Yeah, and then you go on the green button that Sarah was telling you.
Yes, green button. Sorry for that.
No, that's okay. No problem.
Yeah, I
No
opened
problem.
this.
We have this problem every time in the
Yeah.
so
It's
otherwise you can send
yeah.
Yeah,
Just now.
great.
Perfect. Perfect.
Okay, is that one right? Okay, great.
Yes,
Thank
yes.
you, Olga.
Perfect. Firstly, let me introduce myself because I'm quite a new person. My name's Olga, and I'm from the Czech Republic, and I'm a chair of Czech Myositis Working Group, which operates under the Czech League Against Rheumatism. And I would like to share with you our activities, which we prepare for our patients. Yeah, this is our logo of the Czech League Against Rheumatism, and this is a logo of the small group, which is very new. I found it in 2020. That means the Czech Myositis Working Group has been operating since 2020. And this is the team of the Czech League Against Rheumatism who prepare these activities.
We can see the slide in a presentation modality. I don't know if it's solely my problem or.
Okay.
Yeah, so you need to click at the bottom where bottom right, where you have also the magnifier, let's say, with plus and minus, and close there is this little icon close to the minus on the corner right.
Right corner?
Yeah, on the bottom, not on the top, on the bottom.
On the bottom?
Right?
Yeah.
There is this little icon close to the minus, and then there is this bar.
No.
Because this is what I have here on my computer. Otherwise, this is in another language. I don't know. Otherwise, you go. I guess it's on the top left.
Left.
Always in the corner. There is this save icon, and then the two arrows, and then the fourth one. That should be the presentation mode, if I'm correct.
Wow. Sorry for that.
Otherwise, you can send the slides and we can share for you.
Yeah, that means it's better to send my presentation to you, and maybe at the end of this to present my program. This is okay?
As you want.
As you want. Yeah, that means I will just now I will finish and send maybe Ilaria this my presentation.
Yeah.
And,
otherwise, sorry, Olga. Otherwise, you just click on second slide and so on. If you cannot do the presentation, just click on with the arrow on your computer, and that's it.
Yeah.
Try.
No, there is no. It doesn't work.
I think, if I may suggest, now we can have Oliver's presentation.
Yeah.
And in the meanwhile, I will arrange everything with Olga.
Okay.
Yes.
Thank you, Ilaria.
No, my pleasure, my pleasure. So Oliver will talk about Duesseldorf campaign against undiagnosed rheumatism, the D-KUR. So please try to explain first, Oliver, what this acronym means. Thank you.
Yes, Ilaria, thank you for the introduction and greetings from Düsseldorf. It's a German transplantation of Düsseldorf campaign. It's in German with the K of undiagnosed, it's the U, and rheumatism is the R. So it's very easy if you know. And due to the shortage of time, I have some half-German slides which are explained because it would have been too much work for me to do that. So I first share my screen. So everybody should see it now.
Yeah.
And now we all have a need for more rheumatology. And especially in Germany, we have only one rheumatologist in 200,000 people. So we have a lot of work to do, and we have a long time for first referral to rheumatologist, and that is bad for people with common inflammatory rheumatic diseases like rheumatoid arthritis. And it's really bad for people with rare rheumatology disease like the connective tissue diseases. In addition, we have a budget cap for the rheumatologists, so the most of the rheumatologists don't want to see any more people because they are not reimbursed for looking at more people. And we have very little knowledge on rheumatic diseases in primary care, as we have only few universities in Germany who have a rheumatology unit, so only few medical students are taught in rheumatology probably at patients. So less than 1/4 of appointments to a rheumatologist are justified, and 2 or 3/4 of the people referred don't have inflammatory rheumatic disease. And rheumatism makes everything a torture. Early detection saves us from that, and we have a need for more interest in rare diseases. And the rheumatologists just care for the common diseases because we don't have approved drugs for them. We have no commercial interest, and we have less scientific impact caring for the rare diseases. So it's bad for rheumatology, and it's much worse for the rare diseases. And here an example of the referral times for rheumatoid arthritis. We have a mean time of 24 months for the first referral to rheumatologist, 2 years, and median at 1 year. So more than 50% of our patients have to wait for more than 1 year, even with rheumatoid arthritis, or more than 2 years with psoriatic arthritis in 1994. And it has not improved that much in 20 years. And we are still now with the majority of patients seen at after 1 year. And the best step to start for new age is to start at the students. And as we are one of the few rheumatology units at the university, we have to do more work. And we say student education and training should touch all aspects of being a health professional, and that introduces to rheumatology too. So we have to have health advocates for patients, managers, collaborators, communicators. They have to be professional, and they have to be schoolers. They have to teach also to their co-students and interprofessional to other professions in the health systems. We know that medical students may not know or recognize all rare diseases because there are too many, but they can learn a step-by-step differential diagnostic approach to go near to the disease. But however, this can only be done in everyday practice and not learned in a book. So we have a patient-based education program at our university for all students, and we have clinical traineeship for maturity, clinical traineeship at the family doctor. We have clinical examinations which show us that the students know what to do. We have the bedside teaching and show the students, and then the students have the patient's admission and presentation. And later they have a case conference where the student A explains to the other students what he has seen and what is his diagnosis and what is the treatment, and learns from that presentation and treatment and all the other aspects. And our program now is an additional program which is mandatory for some students who want to make a deeper learning to rheumatology. And we asked us, is it possible to transfer medical services to medical students, because we are so full with our work, and could we give some of our work to the students, and do the patients accept a diagnosis from students, and what is the clinical consequence for the patient? And this I want to show you. So here I show you the steps. The students take over a survey, investigation, documentation, performance, presentation, and they write the letter to the patient. And the rheumatologist takes over an introduction of the system D-KUR, a supervision of the students, and the acceptance of the later letter and examination of the students. So we give a seminar for the students and tell them what they have to do and what the diseases they could expect. And then 1 or 2 person teams of students make the anamnesis, clinical examination, preparation of written documentation. And the working diagnosis is presented to the attending rheumatologist, who checks or corrects the students. And then further diagnostic will be determined together, and the students arrange that. And we have a preliminary final discussion conducted by the students in the presence of the specialist to the patient. And the patient at the same time gets a provisional doctor's letter. And finally, when all the lab values and X-rays are examined, there's a final letter issued, and it's written by the students and later accepted by the rheumatologist. So we have most of the steps done by the students. So here you see some photos of explanation, investigation by the students. They discuss it, they make the investigation, and later together we do some special things like ultrasound also together. And this introduces the students more to the daily life at the outpatient clinic and gets them at work more intensively than when they learn in books. So what's the student's perspective? What are their expectations to this course? They're looking forward to the patient's reaction on their work. Do the patient accept me as a future doctor? They expect to gain practical competence, and they want to get more insight into rheumatology. And they want to have more practical experience, develop their own research strategy, complete and evaluate their own findings, and examine after doctor's consultation. They want a recognition of typical pathologies and treatment, and know more about treatment even on non-inflammatory diseases. And what's the patient perspective? They have been asked previously if they agree with the student evaluation to get an early referral. So they usually get a referral after 1 week after asking, and not waiting 1 year. And most of the patients say, oh yes, that's nice. And we ask them on a 6-point Likert scale how satisfied they are with the student and with the doctor and with the system. And 1 is very good and 6 is extremely unsatisfied. And you see waiting for appointment, waiting time in the unit, and flexibility is not that good, but competency of the student and the doctor is very, very good. So the acceptance of the student, they listen half an hour to the patient, they write down all their symptoms, and that is very, very important for the patients. And they have a documentation of their disease, even if it's rheumatology or not rheumatic disease, they have a documentation. That's very important. They accept that work very much. And they are really satisfied with the quality of medical care in that way and have a high overall satisfaction. And we ask the students after 1 year, like in the Kirkpatrick model, what do you remember from your training 1 year ago in the D-KUR, and The students feel more confident in clinical examinations. They have more overall security for clinical work, routine. They know that in future they have a more structured way to look at causes and at patients, and to have an independent way to do anamnesis, physical examination, and lab values. So they have a big benefit from that even after 1 year. And what's the work of the students? How good are they? So we have a sensitivity for inflammation with the students of above 80%, which was increased a little bit by our seminars, which are improved. And we have a specificity of more than 80%. We improved a little bit the seminars, so we reached about 80%. And the most important thing, if the student says it's not an inflammatory rheumatic disease, the negative prediction is 100%. So in some cases they are not sure and they say we don't know, but in many cases they say, oh, we are sure it's not inflammatory rheumatic disease, and they are quite well with it, with a 100% performance. And what's the advantage for the patient? We have new classified musculoskeletal diseases. It's the first referral to rheumatologist. And I just looked at the ICD-10-M diagnosis, and especially at rheumatoid arthritis as the most common, which is M05 and M06.0. And we have the disease duration, and we have in rheumatoid arthritis a disease duration now at 4 to 3 to 2 months at median. So more than 50% of our patients are in the first 3 months of their symptoms when they're referred with that model. So the rapid date makes a very rapid referral, and only few patients have a disease duration of more than 12 months, which is not our fault. But only on average 7% of the patients have a rheumatoid arthritis, and 60% have any musculoskeletal disease. And what are the diagnoses in all these patients seen by our students? And most common inflammatory disease is rheumatoid arthritis. We have about 7% more common, a little bit more common, the seropositive, and we have psoriatic arthritis. We have gout, CPPD, and most common is osteoarthritis, of course. And now we come to the connective tissue diseases we focus on. And in this 10 years, the students detected 24 patients with lupus, 3 with myositis, 21 with scleroderma. They detected 33 with Sjögren's syndrome, 37 with hypermobility, 31 with undifferentiated connective tissue diseases, 3 patients with relapsing polychondritis, and not in the M10, but others is antiphospholipid syndrome. We had 23. So about 5% of the patients referred to a rheumatologist with a new diagnosis have rare connective tissue disease, and 175 patients with rare connective tissue disease were detected by the students with this extra termination for the patient who otherwise did not have the possibility to come to a rheumatologist if the students would not have done the work. So it's a big benefit for the patients. And we don't have a randomized referral system, so we only have cross-sectional comparison of, I took the most common disease, rheumatoid arthritis, and I could compare our university to other universities in Germany, and all rheumatologists who give the data to the Deutsches Rheuma-Forschungszentrum, the German Central Center for Kerndokumentation. And our patients have the same rate of rheumatoid factor CCP and CRP positivity, but on average, we have 7% more employed, 27% reduction in incapacity, more than 1/4 has no everyday problems more than in the other cohorts, 13% more have a sound health. We have 50% more of patients who, due to their early referral, had the possibility, meanwhile, to stop their DMARD therapy and on a therapy-free remission with rheumatoid arthritis. And we have about 20% less use of biologics in those patients. So we have a big patient's advantage to standard of care with long-term to first referral. So we see more patients and free therapy for remissions and less frequent therapy changes, fewer biologics, in addition to the knowledge of the diagnosis in between 2 weeks after they request for referral. So we have a lot of advantages. Thanks a lot. We did some publication on that. Is interested, but most of them are in German because it's more German project up to now. Thank you very much.
Thank you, Oliver. I see we have a question from Coralie, our ePAG of Sjogren.
Yes, thank you. Thank you, Ilaria. Thank you, Oliver, for this very interesting and impressive presentation. I have just one quick question. The patient, do they need to have a referral letter from their GP to access your center?
Up to now, they have to have a referral from their GP.
Yeah, they can't take themselves the appointment. Okay.
Yes, but usually the patients could organize it, and the GPs don't say no, we don't send you there.
Okay, that was my question. Thank you, Oliver.
Thank you, Oliver, for your answer. And Eric, please.
Yes, thank you, Oliver, for sharing that, because the benefit for the patient is obvious. For things. The question is that program dedicated to pre-graduate students?
It's dedicated to students after they got some training on the theory of rheumatic diseases. So usually they are in the 5th year of their university career.
So they are pre-graduate students.
Yes,
so
yes.
It's important. Discussion is open. Should filière ERN work for pre-graduate students? The question is open. But if this improves the quality of care of patient, fact, it's the most important.
Yeah, but in addition, if we have some slots free, we take the postgraduate students to. In addition to the work at the ward, and they have a benefit from that too and have a lot of fun doing that work because they are really doctors in that setting and they get a lot of reimbursement by happy patients who are very happy that someone listens to them and gives them an answer on what they have. So that's very important.
Thank you, Oliver. I have a quick question. I saw that, if I'm not wrong, you focused more on rheumatoid arthritis. Have you seen any differences with rare diseases, different outcomes?
I could give better data on rheumatoid arthritis because it's much more common and we have more cross-sectional data on that. And with 3 patients with myositis and 20 patients with scleroderma, it's hard to give data on the impact of that of that system. So I just evaluated only those diseases which are that common that we could make that statistically sound. So
this makes sense. This makes sense.
If you have the disease and you know it after 2 weeks, it's better than to know it after 1 year. And in addition, if you don't have the disease, it's even much more important to know it after 2 weeks than to wait 1 year with the knowledge I might have lupus, I might have scleroderma with Raynaud syndrome, but it's excluded. And I think both have a benefit, those who have it and those not, even for psychological.
Sure. Also to say that Dr. Google is not the expert.
Yeah.
Oliver. Sarah, please.
Sarah?
I think Sarah,
Yeah.
You had your hand raised.
Yes, I had some problem with the internet line. Just a very quick question. Do you have any experience on program like these in postgraduate students in medical doctor in.
We discussed to open that even to GPs to learn that, but up to now we are just filled with our own students, and first of all we want to do that for the students, but probably it's a good idea to invite GPs or so, but it needs time, so they have to come for 4 weeks until they are really professional, and most of the postgraduate don't have the 4 weeks of time to do that training.
Yes, thank you.
Thank you. Sarah, do you want to introduce the next?
Yes, we can move again on Olga. Do you have the slides, Ilaria? So please, Olga.
Yes.
The floor is yours again.
Thank you very much. Yes, I think that Ilaria, you can continue the next slide because I introduce myself and show this logo of our Czech League, and yeah, you can go next. Yes, this is the Czech League against the rheumatism team. You can continue this. The next one. Yes, the first what I would like to mention is a project Health Literacy Academy, which we prepare for patients. Just now in May, we started the 3rd year of this project. Last year, we focused on organ involvement in rheumatic diseases. We've got more than 15,000 unique views in 2022. You can see this poster for each webinar. We prepare poster, and this one was broadcast in August last year and focused on skin involvement in rheumatic diseases. Thank you very much, Ilaria. You can continue the next one. And because I'm a chair of myositis patient group, last year we prepared during May, because May is month of myositis awareness. We prepare again a webinar with expert or rheumatologists from Rheumatology Institute in Prague. Yes, and we've got a number of views. Yes, and this is a webinar from this year, Myositis Awareness Month 2023. Yes. Next. Yes, there are some another examples of webinars which we prepare. For example, the first one, word of osteoporosis and psoriasis. Yes, and World Day of Osteoporosis. These are next examples of these webinars which we prepared last year. Ilaria, please, the next one. And the next activities which we prepare for patient is a workshop with psychologists and coach. The first one, we focus on communication, not only with the doctor. I think that we know that communication between patient and the physicians and doctors is very important for positive treatment and support the quality of life of this patient. This is first one, and second one is how to manage your illness. Yes, I attended both these webinars, and we've got feedback from our patients, and these all workshops are highly appreciated. Ilaria, thank you. The next one. And last year, for the first time, we prepared workshop with a psychotherapist. I will speak about this workshop a bit later. Yes, Ilaria, you can show the next. This is the quite new project, and it's called Rheuma Consultation. It's consultation with psychologists. How does it work? Patient can open these web pages www.rheumaporadna.com and fill in an online form. Next day, the assistant of this doctor contact this patient and choose the date for consultation. There are 4 consultations for each patient free of charge. And again, because it's quite new project, which we started at the beginning of the year of this year, and it's only for patients with myositis and scleroderma. Yeah. Ilaria, thank you. And I would like to mention some activities which I prepare only for patients with myositis last year, because I focus on quality of life of this patient. The 4th Global Conference of Myositis, which took in Prague in last year, I was a member of international team which prepared psychotherapy and occupational therapy workshop, included theory of exercise and practical guidelines, and focus of activities of daily living with myositis, including energy conservation techniques, compensation, etc. Because there were 2 conclusions sent to patients from this conference. The first one, exercise is considered medicine and complements medication, and cooperation between patient, rheumatologists, pulmonologists, etc. Is absolutely necessary to improve the quality of life patient with myositis. Ilaria, please, the next one. Then in September last year, I prepared a psychotherapy workshop. Again, there were a practical part and theoretical part, and at the end, patient received materials which demonstrated exercise. Yes, the next one. Thank you. And it was the top of these activities. We exercise with myositis in cooperation with the team of the Center of Therapeutic Rehabilitation of Institute of Rheumatology in Prague. We prepare an information booklet on the basis of set of exercises that patients with myositis can perform as a part of individual exercise at home without supervision. At the end of this booklet, patient can find answers to the most frequently asked questions related to the rehabilitation treatment. And these booklets are distributed to patients through rheumatologists and psychotherapists from the Institute of Rheumatology and are placed on our website. You can see, and the picture illustrates the team because I demonstrated all these individual exercises, and there is a team of psychotherapists. Thank you. You can continue. There is the front page of this booklet, and you can see some examples of these pictures which are in this booklet. Yeah, thank you very much. And at the end of my presentation, I would like to share with you this year's campaign because just now this campaign is still running. We started the preparation of this campaign at the beginning of this year, and we launched this campaign in May because, as I mentioned several times, May is month of awareness of rare disease myositis, and the part of this campaign was pictures which have been taken by artist, photographer. The first picture, we got 10 patients. The first picture illustrates the patient in natural beauty, if I can say, and the second one draw attention to the limitation associated with this disease. Yes, then we prepare patient testimonies and stories and press release and TV broadcasting or discussion. I participated in this discussion with Professor Wensowski, and then half of our radio broadcasting, and these patient testimonies or stories were published in several Czech national journals, and just now we are preparing 3 exhibitions in Prague. The first one in Health Ministry of Health, and the next one may be in some exhibition spaces in Prague. Yeah, thank you very much, Ilaria. Yeah, this is again. Thank you very much. Thank you very much for the obstacle from the beginning of my presentation, and thanks, Ilaria, for arrangement of this presentation. There is my emails and web page and Facebook. And thank you very much for this attention. And if you have any question, it's my pleasure to answer it.
Thank you, Olga. It was wonderful, actually, really inspiring. I know that our communication manager loves this kind of campaign, and she's writing in order to probably plan something and help you. Eleonora, are you here? Yes.
Yes, no, yeah, I'm here. I mean, I really love this kind of campaign where you have these pictures and, you know, you don't see the let's say the patient, but you see the persons. And this is very important because if you see the persons, you give them the dignity that you need to have, that you deserve. And once you have the dignity, then you have equal rights.
Yes.
For the healthcare system. So that's very important. And from a communication point of view, that's very powerful because we tend to think about patients, you know, like poor people, oh, poor you, I'm so sorry for you. Fine, yes, but you deserve dignity. And the dignity, I guess, and I strongly believe that is coming by seeing you as persons and going, you know, much you're much more than a patient, you know, honestly. So that's very, very powerful. And besides, those are very beautiful pictures, by the way. I mean, I don't know who took them, but those are very, very beautiful pictures.
These photos has been taken by artist photographer.
Yeah, I mean, yeah. So we will be in touch with that. If you can share with me more info, I would love that. Thank you.
I couldn't agree more with Eleonora. And let me say that the first picture of the lady with the stair in front of her after your picture was had a deep impact. So the stair difficulties, even not being able to make the first step of the chair. So really, really great. Thank you, Olga. And again, we would be happy to help you disseminate your material because, you know, having you on board has been very difficult because we couldn't find a patient organization, or we also had for sure the barrier of the language. So I believe that myositis deserve more attention than other popular diseases. So disseminating this education material could be, could fall really within the scope of ReCONNET.
Thank you very much, Ilaria, but there is a problem because all these materials which I have been prepared are in Czech language, yes.
But I think we can make it somehow. Yes.
Yeah.
We'll find a way.
No problem, because at the beginning, because as I mentioned, this is a very young association because I founded it in 2020. And the first step which have been done was information booklet about we are living with myositis. There are information about this disease, about diagnosis, about living style, and so on. Yeah. Just now we've got two information materials for patients.
And we will have also Michaela Linkova for sure to help.
Yes,
from the board. Yes,
we cooperate with Misha. Yeah.
Yes. So now I would like to introduce a interesting session by our Florence full member, Professor Simonini, a stepwise approach in the organization of care during transition from pediatric to adult age, reporting the protocol of a monocentric experience. I'm looking forward to hearing this presentation as the transition is quite a challenge, but really important because the word for the patient dramatically changes, suddenly because not always there is this really transition. So please, Gabriele, let us know your experience.
Wow, thank you, Ilaria, for this kind of presentation. I don't know if you are growing so much expected from this talk, but we are going to present to all of you just our experience, how we are going to do what probably has to be done. And let's see if I'll be able to share the screen. Not so easy. Okay. Does it good? Is okay?
Perfect. Thank you.
Okay, that's one of the first step is done. Okay, what this? Well, a brief introduction just to let you know, but probably you're already aware about this, that transition is really an issue, and there are already plenty of literature addressing this topic. But in my opinion, there is a different cut between theory and practical point of view. As you may see, these are some of the summary cup coming from the Euler press recommendation. Press is, press is the Paediatric Rheumatology European Society. So there was an effort between these two big society. Euler is bigger than press, of course. I try to address in a common way, in a joint way, this kind of issue, because it's going to be a burning issue. And there was even an effort, a tentative effort from the Italian society. So the adult community and the pediatric community tried to follow in the Euler and Press advice to focus the issue in our practical situation, our local situation. What we learn from this literature, in my opinion, is that we need to customize this process, because there are several issues that has to be taken care, because of course this kind of issue cannot be left to the personal, emotional, or effort of the physician, adult, as well as pediatrician. But there will be a common effort considering organization, health organization, available human and economical resource. And okay, so if we would like to summing this potential key principle of the transitional care, we have to say that it has to be a multidisciplinary approach. There is no negotiation about this. This project cannot be left just to the physician, but several other healthcare providers has to be involved into the approach. The plan has to be individualized. We need to tailor for each patient, for each adolescent, a specific program in order to carry on the transitional care. Since our principal aim will be to guarantee to this patient, this subject, a continuity of the care. But in my opinion, these are all probably good words, but we need to go in deeply into the real practical point of view. How we can manage this fantastic and terrific statement, but they have to move on to the real practice of every single day of the care of the patient. So we would like to share with you what we are doing in our clinic, and obviously this is not anything, everything can be do better. This is not, of course, something wrote into the stone, but it is how we decide by now to take care about this problem. And I can guarantee you that this first step that is already stated in this slide was, in my opinion, our most terrific effort that we tried to reach it, because we brought people that are not totally used to serve as a clinician, and of course they are not deeply involved into every single clinical issue that can be offered during a practical single-day life, in order to address that, okay, we need an administrative organization in order to build up a fixed joint clinic that has to be standardized between the pediatric hospital, the Meyer Children's Hospital where we work, and the adult hospital where the rheumatologist and immunologist unit can be involved in order to join us to take care of this patient over the transitional period. So we defined a written agreement between these two organizations in order to precisely define who has to do what. That's a key point. And so then we build up a shared agenda in order to have a joint clinic between adult and pediatric rheumatologists. We summarize the process that we are going, that we actually do in our transitional care program. The first step will be to identify the candidate. So all of us perfectly understand and know that there is a window of age in order to make the transitional care. But for each patient, the age is not like a magic date where, well, now you can move on to the transition. This is not the issue. We have to identify in a multidisciplinary team as much as we can, including physiotherapists and psychologists, of course, who is now deserved to move in a transitional period. And this cannot be always at the same age. For some patient, for some child can be 14, and for another child can be 18, but they have at the same level an equality step to move over the transitional care. And of course, we decide to have some mandatory item in order to identify the patient, the children, as eligible to be transient. And of course, we decide to not move children who have an active disease. And the other issue is related to the therapy. At least that there are no unexpected medical event, we do not move to the transitional clinic a patient with active disease and that is going to withdraw the systemic treatment. And then the second phase will be the bridge, a key period, a key moment in order to have a transitional point of thinking, I would say. We stated that in this shared agenda that we try to make a joint multidisciplinary evaluation as according the different need of the patient, of the child and his family, try to bring into the process even other health professionals that took care about this child over this childhood chronic rheumatic disease. And we precisely anyway defined that even though in the same room at that moment, at the first moment, we have an adult and a pediatric rheumatologist until the transitional care process is totally defined as concluded, the patient is still under the care of the pediatric unit in order to offer to this child and his family in this critical period of his disease, a strict point, a firm point in order to receive any need in this special period of his life. And then try to build up the new house for this child that are moving into in a new part of his life, their life. So the second evaluation will be at the adult hospital in a room belonging to the adult hospital, where anyway the patient and his family still can have the chance to find the pediatrician and again the adult rheumatologist in the same room. So in a different room, the same actor are still present for the need of this child. And of course, we try to again rethinking about the ability of this child to be now ready for this new life, this new period. But again, after a multidisciplinary approach, if we think and including in this decision the child, that the time is not yet ready for making a complete transitional of care, we move to the next consultation, but still into the adult hospital building. Of course, this is just how we try to do transitional care. Obviously, we are open to discussion. We are open to receive all your feedback and how you are doing in order to improve the quality of care of our child. But we are truly persuaded that transitional care has to move into the clinical practice point of view, and this process has to be tailored, individualized for each single patient. There are obviously some common and, if you want, standardized process that has to be used, but of course, at the same time, tailoring and customize this project is a mandatory issue. Inside to the ERN ReCONNET, we are trying to build up a transitional project, and of course, any feedback from you are more than welcome. Thank you for your attention.
Thank you, Gabriele, for your nice presentation. I have actually a question for you. You have presented a good practice. What do you think is needed to make this become a normal practice?
Well, first of all, I think that this is a proposal. I'm not sure that this is the real good practice. So that's, I think that the sharing the experience across the different country, across the different centers is the good thing in order to have a common project. That's first point number one. But the second one, in my opinion, is that we have to be truly dedicated to this part of our clinic, because it cannot be left to, okay, this is a second point. I have to take care of my clinic, so a sleep patient in childhood and a JA patient in childhood. But this is, of course, a point that has to be addressed with the same effort of any other outpatient clinic. That's what I think, at least.
Thank you, Gabriele. And now we have a question from Oliver Zander.
Thank you for the presentation. I have a question on the adherence of the young patients when they are in the adult care, because we see we have an SOP for the transition, which is a little bit like yours, with joint interaction, and after that the young patient are grown up, and as a part of getting rid of the parents' control, about 1/5 does not come to the appointment later because they say, now I'm the chief of my disease, and I say, oh, I don't want any further controls, I don't want treatment, I want to be free of all that, and they don't come, even with the best course of transition made before. Do you see that in your system too, or is it perhaps a special problem of our children?
No, I think that you're totally right, because of course, as a pediatrician, we have to take care even to the family. There is no negotiation about this, okay? So child is still belonging to the family. That's no negotiation about this. But in order to increase the responsibility of the child, we have to move on, in my opinion, slowly, not dramatically abrupt, in order to leave the child to become, as you said, the chief of his disease, and live into the, let's say, into the cloud, or a step forward behind the family. But of course, at least in Italy, according rules of the regulation, up to 18, a child is not free to be alone in a room in front of a physician. So this is a matter to be discussed. Obviously, we try to move to the child to be the master of his disease, but you can neglect the family up to at least 18 years old. And this is another reason, because the age of a transitional care, at least in my opinion, has to be very flexible and not really restricted. Obviously, you cannot start transitional care at 20, but for what is the time at 14 for another child with his family, the transition can be a little bit moved to probably 16 or roughly to 18. It depends. Any trio is different from other.
Thank you again, Gabriele. Sara, you have a question.
Yes, thank you, Gabriele, for this nice presentation. A question regarding the adult rheumatologist point of view. I mean, transition means that someone, in this case, a patient, a family, caregiver, comes to a center, or a clinician to another center, to another clinician. I love it so much in Brussels, some words that you said regarding the fact that the adult rheumatologist in many cases say, okay, this patient has not something of a connective tissue disease or other, since they have very different features in the pediatrician, in the pediatric age, and the adult age. So my question is, do you think that transitions should foresee also training and education, especially for the adult rheumatologist, and especially for the stage from 13 to 18?
Well, since I totally agree with you, with your back thought, in order to build up a proper transitional care project, obviously, we have to take care about learning each other. I mean, I'm a rheumatologist, but I'm a pediatrician too. So just to be really clear, I'm not want to teach anyone to any other, but a juvenile idiopathic arthritis is not rheumatoid arthritis, even though this child is now 20 or 24. The disease is different. Obviously, there are sharing phenotype of the disease, but you, as a adult rheumatology, you cannot think, in my opinion, to treat this 35 JIA patient as your 35 rheumatoid arthritis patient. That's for the disease that much more close resembling rheumatoid arthritis, your disease, your leading disease. And this is much more different from connective tissue disease. Our phenotype is not exactly the same that the phenotype that you are expecting at that age. So just small sign that you think that can be not problem, are the leading problem in our childhood age. So, and obviously we need to learn each other. So as pediatrician, I need to learn from adult, but please, even adult need to, let's say, understand, not learning something from pediatrician. That's my personal opinion, of course.
Thank you, Gabriele.
Yes, we are here for this, from learning, learning from each other. Yes, and Professor Smith has a question for you.
Yes, I would like to add on to Gabriele and Sarah. In systemic sclerosis, we see the same. Phenotypically, juvenile systemic sclerosis is not the same as adults. And what we do with the systemic sclerosis community is we sit together once yearly with all pediatricians, 80% pediatricians, and some adults to convene about how to evaluate the disease in children, so that there is a feeling from both sides, the peds towards the adults and the adults towards the pediatricians. So Sarah, I think it's a very nice question. I think both sides should feed each other.
Yes, agree. Totally agree.
So thank you very much to Gabriele, but to all the speakers. I think we had a very interesting afternoon. I have learned many things and happy to help all of you as ePAG if you need it. It's our duty and our also happiness, let's say, to help each other. And now I leave the floor to Sarah and Marta for the closing remarks. Thank you.
Thank you, Ilaria. Just a very brief comment from my side. I have to say that in many cases, sharing is not always something that comes easy. But in the framework of ERN ReCONNET, especially, it happens very easily. So it is a very big thing. At the end of these 2 hours, we can say that for sure we will be richer than and more inspired than a few years ago. So thank you. And thank you also for the next events that we will plan. So thank you to all. I give the floor to Marta.
So I'm always the last one to speak. And so I'm always the one who says, I agree with what Ilaria and Sarah just said. Well, I think that these 2 hours were not only inspiring, but really were very fast, because it was so interesting to move from one experience to the other and think how we can also bring this at home and implement this, because this will then be our work, so that we can learn from each other and then improve what we do in our clinics, maybe adapt what you do in another country to what we can do in our countries, because obviously we have different healthcare systems that we have, but sharing these experiences obviously is very important to fill the mandate of the ERNs, that is among the many mandates we have, is the one to give to all patients everywhere the same care that we can offer in an affordable way, but try to actually establish the level of care we have to give. So by sharing the experience, obviously, even points of view, one could say, oh, this I could do, this I could improve, this could be changed. And so it was really very interesting. So I'm looking forward to the next meeting where everyone, we can also continue sharing the things that we do, because this was really at the beginning, and I agree, Ilaria, that no one must be left behind, and that's why we share here, because it's really on this that we can build new things. We work on pathways, we work on many things together, but we shared already, for example, for RN Path, how we manage and what we do in our clinics, but discussing this today was another way of sharing. So thank you very much. I think it has been a very successful meeting as well, because we reached a real big number of colleagues who have participated. We have recorded, so we will see our discussion as well very soon, the recorded one. So it will always also be there for, those who were not able to be with us during these 2 hours. So thank you again, and have a nice evening to everyone.
Bye-bye. Thank you.
Bye.
Thank you. Bye.
Bye.
Thank you all. Bye-bye. Thank you.
Ciao.
Bye.
Bye.
Bye.